Bismillahirrahmanirrahim. Dear students, today we'll discuss pericardial diseases. Primarily, we'll discuss pericarditis and its complications like pericardial effusion, cardiac tamponade, effusoconstrictive pericarditis, and constrictive pericarditis. You know, pericardium is a layer which covers the heart. There's a visceral pericardium which lies over the heart, and then the outside vessel is the pericardial cavity, and then comes the parietal pericardium. So it's the inflammation of the pericardium which leads to these complications I have already mentioned. The commonest cause of pericarditis is idiopathic or viral. But patient can suffer from pericarditis on day 2 or 3 of acute myocardial infarction or after a week of acute myocardial infarctions. Then there are infective diseases like bacterial infections and tuberculous pericarditis. It's a complication of dissecting aneurysm of aorta. Then there's traumatic pericarditis, malignant disorders like CA breast and bronchogenic carcinoma can infiltrate pericardium and can cause pericarditis. Uh, Pericarditis is a feature of chronic renal failure. We call it uremic pericarditis. And then it's a common feature of connective tissue disorders like SLE and scleroderma. Uh, Pericarditis presents you with chest pain, which is precardial or substernal pain, and this pain is pleuropericardial. It's localized and it worsens, it increases intensity with breathing. So actually, the patient with pericarditis hold his chest, compresses his chest to just get rid of pain of pericarditis. The pain of pericarditis is usually localized, but it may radiate to shoulder or left, sometimes along the left border of the outer border of the left arm. Uh, the pain of pericarditis worsens when the patient lies flat, and it improves when the patient sits forward, leans forward, and hold his breath. Of course, the patient of pericarditis may give you history of fever or some infection uh, week before or days before the onset of symptoms. So you should take the history, and after that history, you should examine the patient, and you must auscultate the heart. The most important finding is pericardial friction rub. It's a superficial, leathery, scratchy sound which you can auscultate uh, by putting your stethoscope on the precordium, and it's better audible when the patient leans forward and you press your stethoscope. It's a scratchy sound and it has three components: systolic, diastolic, and late diastolic. We call it uniphasic pericardial rub, biphasic pericardial rub, or triphasic, depending upon which component of the pericardial rub is audible. ECG shows ST elevation with concavity up. You must remember that in acute myocardial infarction, the ST elevation is upward convexity. But as you can see, the arrow showing ST elevation with upward concavity in multiple segments of the in multiple leads of electrocardiograms. This is a very important finding of acute pericarditis. And when pericardial effusion develops, although the patient may feel some ache in the pericardium, but there are no other symptoms. The pulse may be normal, the blood pressure may be normal. The only finding on examination of pericardium is distant or muffled heart sounds. And then you order an X-ray chest and ECG and echo in this patient who had developed pericardial effusion. And ECG shows non-specific STT changes and sinus tachycardia, T wave flattening, or sometimes a T wave inversion. X-ray shows enlargement of the heart with no vascular marking and no evidence of chamber enlargement, say globular enlargement of the heart. Echo is a very important investigation, and you can nicely see in this echocardiogram, parasternal long axis view, there is a echo free space beneath left ventricle, and this is pericardial fluid. And it's very important investigation to diagnose pericardial effusion. The treatment of pericarditis is you give salicylates and bed rest is important, and most of your patients respond to this treatment. Cardiac tamponade is a condition in which there is pericardial effusion with increased intrapericardial pressure, and that increased pericardial pressure doesn't allow the ventricle to relax, and the chambers, particularly right ventricle and right atrium, are compressed. And when the chambers are compressed, there is poor ventricular filling. When there is poor ventricular filling, there is very low ejection fraction. When there is very low ejection fraction, then what will happen? The blood pressure will go down, the patient will become dyspneic, the patient will become drowsy, and there will be sinus tachycardia because of increased sympathetic discharge, and these are the signs of cardiac tamponade. The basic pathophysiology is increased intrapericardial pressure, not allowing the ventricle to relax and accommodate the blood during diastole. Complications of pericardial effusion, cardiac tamponade. These patients have discussed high intrapericardial pressures and compression of the right ventricle and right atrium. And the clinical findings: hypotension, tachycardia, raised JVP with loss of Y descent. Only X descent is present. His pulses paradoxus, and the heart sounds are distant and muffled. ECG shows uh, ECG shows electrical low voltage complexes and electrical alternance. You can see One complex is tall and other is small. This is due to swinging of heart in large pericardial fluid. The axis of the heart is constantly changing and there is electrical alternance. A very important and specific finding to diagnose cardiac tamponade. Echo shows large pericardial effusion and you can nicely see the compression of right ventricular wall in these patients. Very important evidence of cardiac tamponade, the compression of right ventricle. And of course, the treatment is that you have to remove the fluid, and that is called pericardial centesis. Constrictive pericarditis is a condition in which, because of chronic pericarditis, due to chronic pericarditis, there are multiple adhesions, thickening, and calcification of the pericardium, and the heart is now covered with a shell-like thickened pericardium which is calcified. So it is not allowing the ventricle to relax, left and right ventricle both. They are not allowed to relax completely. So again there is poor filling of the both left and right ventricles. The constrictive pericarditis patient presents you with symptoms of right heart failure. If you do not examine the JVP of these patients properly and you miss the JVP, you will diagnose this patient as suffering from cirrhosis of liver because they present to you with abdominal distension, they present to you with enlarged liver, edema of feet. But the most important finding is the raised JVP, and then on auscultation of the pericardium, there is a sound, high pitched sound in diastole, which is called pericardial knack, a pericardial knock. When this is due to the abrupt distension, relaxation of the ventricle during diastole. Blood pressure is low. Pulses paradox is present in 30% of the cases. If it is present, then you should think of combination of constriction and effusion, effusoconstrictive pericarditis. Pulses paradoxus is a feature of cardiac tamponade. Uh, and then, of course, the common arrhythmia in constrictive pericarditis is atrial fibrillation. The JVP is raised and there is a rapid wide descent. And X-ray chest lateral view shows calcification around the heart. You can see on the right side lateral view the white shell-like calcification outside the heart. You can see the left ventricle is surrounded by a shell-like calcification, which you can nicely see on CT chest. So this condition is called constrictive pericarditis. The medical treatment is supportive. You give diuretics to reduce edema, give digoxin for atrial fibrillation, but the definite treatment is surgical removal of pericardium, which is called pericardectomy. So this was all about the pericardial disorders. Thank you very much.